opening speaker next is Dr. Gerben Randgras. It gives me a great pleasure to introduce him. He's a professor of anesthesiology and critical care at St. Louis University, Missouri. He's director of transplant anesthesia, director of quality and patient safety. He has numerous leadership roles at ASA and SATA, and he's trained. I probably asked him to talk to my colleagues and my former trainees and my current colleagues, so I'll have to talk to him a little bit more afterwards.
Thanks, Martin, for that great talk. This is a precursor to the talk that I'm going to give now. This is the first time we're talking about NRP formally in the ILTS SATA meeting. I will say I don't have any disclosures relevant to this presentation, but also I wanted to tell everybody I'm not an ethicist. While we'll probably describe the ethical concerns related to NRP in this presentation, my goal is not to convince anybody whether the practice is ethical or unethical. We'll start with a case and then move on to what is NRP, its history, outcomes, and legal, ethical landscape of NRP across various medical societies. And then we'll go ahead and conclude with some of the recently published work on donor brain blood flow under NRP and clamping of the supraortic arch vessels in future directions. So I wanted to start with a case that occurred at our institution and that encapsulates many of the contemporary concerns related to NRP. So over a year ago, a young woman suffered, unfortunately, a very devastating high cervical spine injury. And after it was determined that she was completely otherwise neurologically intact, and after ethics and palliative care consults determined that she had full decision-making capacity, the patient went ahead and decided to withdraw life support and donate her organs. The procurement plan included thoracoabdominal NRP, or as I'll refer to in the rest of the talk, TA-NRP, to recover the heart, liver, lungs, and kidneys. About an hour before the surgery, there were concerns raised at the hospital that reestablishing a circulation in an otherwise neurologically fully intact donor could be seen as a violation of the dead donor rule. Or even some people brought up the term euthanasia. Their OPO, it turned out, had not actually consented the patient or disclosed NRP as part of the donation process, and the case was halted. The patient ultimately proceeded as a DCD donor, but an iatrogenic liver injury left only the kidneys as usable organs. And this challenging situation prompted a hospital-wide debate and a moratorium on TA-NRP across our entire Catholic health organization. So really, this case illustrated how ethical uncertainty, consent gaps, and institutional values can rapidly reshape clinical practice. And the patient was fully competent and informed regarding the withdrawal of life-sustaining therapies and DCD donation, but the patient and the decision makers also had a right to understand all aspects of the donation process. As we learned, NRP improves patient the viability and increases the number of transplantable organs. And proceeding with TA-NRP in this situation could have benefited multiple recipients awaiting heart, liver, lung, kidney transplantation. There were questions about perceived harm and justice and also equitable access to organs that came into play when considering the institution's stance on TA-NRP. And this ultimately triggered a 26-hospital moratorium on TA-NRP to preserve alignment with theological and ethical directives. So at the time of this case, actually half of OPOs in the United States were carrying out NRP without a policy or even a policy pending approval. These were findings reported in a survey of OPO practices related to NRP. But NRP is by no means a very new tool, and it was first developed in Spain in the 1990s, originally for uncontrolled DCD donation for livers and kidneys. The idea was pretty simple, but transformative. After circulatory death, an ECMO circuit could be connected to the donor, drawing blood from the vena cava, passing it through an oxygenator and a heat exchanger, and then returned to the aorta, thereby restoring warm, oxygenated blood flow to the abdominal organs and preserving their function for transplant. The technique then soon spread to France and the United Kingdom, where it was later refined and standardized. And the term NRP was really introduced to emphasize that circulation should be regional, excluding the brain, and in accordance with accepted definitions of death. A major turning point came in the 2000s when early United Kingdom experiences showed that restoring circulation after cardiac arrest could reactivate the heart, and preserve multiple organs. And this actually laid the groundwork for DCD heart transplantation. Over the following decade, then, dedicated cardiac and abdominal NRP programs emerged in Edinburgh, in Cambridge, and Papworth, and the approach was adopted internationally. And today, NRP is routine in DCD liver recovery in France, Italy, Norway, and as part of a TA-NRP in many other countries. So these are common pathways used by many centers for DCD livers that Martin also mentioned that integrate normothermic machine perfusion and NRP. But TA-NRP typically proceeds as follows. So once death has been formally declared, 2 surgical teams begin their coordinated roles. One team opens the chest and clamps the cerebral vessels to isolate brain circulation. The other cannulates the femoral vein and femoral artery to establish the ECMO circuit. TA-NRP is then initiated to restore warm, oxygenated blood flow to the heart and abdominal organs. And during this phase, the heart's also vented to prevent distension and pulmonary congestion while it remains stunned and is still recovering. This approach allows for controlled reperfusion and ensures that myocardial contractility is regained safely before full physiologic circulation is reestablished. Perfusion parameters during this time are then kind of optimized using TEE or PA catheter measurements, sometimes inotropes or additional transfusions to achieve hemodynamic stability. And so really at this point, the native cardiac function resumes, and at that point, ventilation is started and ECMO is then weaned. So basically at this point, the organ recovery proceeds very similarly to a DBD. With the heart, liver, and other organs then have an opportunity to be evaluated to determine the suitability for transplantation. The ECMO circuit also remains primed in case rapid reinitiation of ECMO is needed if there's any instability. But ideally, the heart assumes primary responsibility for systemic perfusion. So here the first image shows what is direct procurement and perfusion. It's no NRP. After the standoff period, the aorta is clamped, cardioplegia is administered, and the heart is removed and connected to an ex vivo perfusion device. And there's no in vivo circulation, no chance of cardiac or brain perfusion. The second image depicts abdominal NRP, and here the descending thoracic aorta is occluded to prevent brain perfusion, and perfusion is restored only to the abdominal organs. The heart remains asystolic, is removed directly, but there's still theoretical concern for limited collateral flow to the brainstem through spinal arteries. This depicts TA-NRP, where the supraaortic arch is, the vessels as seen on the right and lower extremity vessels are occluded or ligated before initiating regional perfusion to the thoracic and abdominal organs. As shown, there's still a theoretical possibility of minor brainstem flow through spinal collaterals. And here on the left, the donor is reintubated and weaned from mechanical support, allowing the heart to sustain circulation independently. And as shown on the right, after adequate reperfusion and functional assessment, the heart's explanted and either cooled or transported on a perfusion device for transplantation. And so you can also see here an aortic clamp can also convert the situation into an abdominal NRP. So why do this? There are several reasons as to why TA-NRP would be preferred over direct procurement and perfusion. In addition to the long ischemic time in direct procurement and perfusion, TA-NRP also permits the in vivo assessment, as we talked about, of heart function, and also actually coronary evaluation, which in some countries is not allowed, but prior to declaration of death. Due to weight limitations, ex vivo perfusion is not routinely used for many pediatric cases, and perhaps the strongest argument in favor of using TA-NRP is the high rate of multiple organ recovery and cost effectiveness with multiple of the studies that are cited here showing significantly higher organ utilization rates with NRP that has major implications for expanding the donor pool. So a few studies have compared outcomes after TA-NRP and direct procurement and perfusion. The results are mixed. So for heart transplantation, one study found a 60% reduction in severe graft dysfunction and with the use of NRP, whereas other studies report actually very similar outcomes between the two modalities and conclude that there's perhaps a learning curve with direct procurement and perfusion where outcomes improve over time with more experience. And when comparing NRP and super rapid recovery without machine perfusion NRP has been shown to improve rates of ischemic cholangiopathy, biliary complications, and early allograft dysfunction. But really no major survival differences between NRP and machine perfused organs have been found, and this is also similar in the kidney literature. So next we'll move on to the NRP landscape across borders and medical societies and various ethical concerns. The next few slides are quite busy. I'm not going to go through them in detail, but I'm happy to send these slides out later if anyone's interested. This slide summarizes various medical societies' positions on NRP. Among them, only the ACP, the American College of Physicians, has come out strongly against the practice. The ACP statement alleges that NRP violates the dead donor rule because it involves resuscitation of the donor and then induction of brain death by way of ligation of the supraaortic arch vessels. The ideas discussed in their statement assert that ECMO initiation could possibly salvage brain function, but that prevention of cerebral blood flow by clamping causes brain death. So across borders, most countries have deemed that NRP use is acceptable, provided that brain flow is not restored. However, there are important differences between the United States and other countries in the legal definitions of death that complicates the acceptability of NRP. The Uniform Determination of Death Act of 1981 allows separate circulatory and neurologic pathways in the determination of death, whereas the unified brain-based models of death that are adopted by many other countries define death solely by the absence of brain function and perfusion. And that framework simplifies a lot of ethical concerns around NRP. So with this kind of understanding, we have to then know that the dead donor rule establishes two fundamental conditions. One is that donors must be dead before vital organs are procured. And two, physicians must not cause death during the process. And so in DCD, death is declared after what we believe is the permanent cessation of circulation. That is, once the heart and brain are no longer perfused and there's no intention potentially to restore circulation. So critics of NRP, specifically TA on NRP, argue that by reestablishing oxygenated blood flow after death declaration, the procedure reverses the physiologic state of death on which the legal and ethical determination was based, which appears to contradict the Uniform Determination of Death Act. So that brings me to the question of whether collateral circulation to the brain exists after supraaortic arch vessel clamping. The concern that's been raised is that collateral vessels could still perfuse the medulla or the brainstem, and that there could still potentially be residual circle of Willis blood flow. And if that were true, any residual brainstem function could invalidate the declaration of death under our country's legal and ethical context. The concern isn't without some merit. Right? There are cast studies of perfusion of the spinal cord that confirm the existence of collateral circulation and an arteriolar network that feeds directly into and indirectly into the anterior spinal artery along its entire length. But when I looked into this, especially some of the recent work that's been published, researchers have failed to find any clinically significant cerebral blood flow in donors placed on NRP. The collateral flow rates have been found to be very low. At least in one study, there were 3.9 cc's per 100 grams per minute. And another study used transcranial Doppler to demonstrate the absence of blood flow. And yet another used digital subtraction angiography and endovascular intracranial arterial blood pressure monitoring to demonstrate that pressures and pulsatility were very similar to that of circulatory arrest, even when the native heart function had resumed. And finally, there's a study that's actually planned in the United Kingdom that will look at this with a larger patient sample. In this Journal of Heart-Lung Transplantation publication, this used a porcine model, and they did show here that there was evidence of delayed superficial arterial fill and limited carotid opacification in half of pigs that were placed on NRP after clamping of the supraaortic arch vessels, but no perfusion into the intracranial territories or resumption of electrical activity in the brain, supporting the conclusion that cerebral circulation was not reestablished under these tested TA-NRP protocols. Lastly, I will just briefly mention that the rapid recovery with extended ultra-oxygenated preservation technique that Vanderbilt Transplant recently published in the New England Journal of Medicine They propose this as an alternative actually to NRP and machine perfusion. So they call this the re-up technique, and it involves the use of an ECMO circuit to oxygenate 2 liters of a cold preservation solution consisting of packed red blood cells, del nido, cardioplegia, and other additives designed to restore myocardial energy, the debt that was incurred during donor death. The solution's administered at a very low temperature, 4 degrees Celsius, at a mean aortic root temperature of 80 degrees over about 10 to 12 minutes. And what they achieved was very, very favorable outcomes, even with very long ischemia times, up to 240 minutes for their heart transplants. They published this was a series of about 3 cases. But it's received considerable attention as an alternative to NRP. And they conclude that this may be something that completely replaces and obviates the need for TNRP in the future. Of course, it's a very limited study. So to conclude, normothermic regional perfusion clearly improves both organ recovery and utilization rates, particularly in donation after circulatory death. Outcomes for abdominal organs appear to be comparable to those achieved with NRP, but NRP may offer greater benefit for thoracic organs, especially the heart. Although there are ongoing concerns about collateral brain flow, the current evidence does not demonstrate any meaningful brain activity or perfusion when the supraortic arch vessels are clamped. And moving forward, it's essential for OPOs to develop consistent, transparent NRP policies. And as technology continues to advance, we may ultimately see less reliance on TNRP to achieve similar results. Thank you.
Thank you very much for that very informative talk. I'd like to introduce our third